Thank you. We know that foreign body airway situation can be sticky and troublesome for the anesthesiologist, and could be fatal to the patient if you are not managed in time with due care. So disclaimer is that all patients' pictures and video were original, and verbal consent was taken at the time of we had taken it. So the foreign body airway that is most common incidence is in the children 6 months to 3 year of age, with the mortality during bronchoscopy is less than 1%, that is 0.42 as per literatures. Why children are more vulnerable age group? Because they have natural urge to explore the objects by mouth. Again, factor is lack of molar teeth to crush the nuts. So the all nuts or foods parts without crushing, they can able to inhale. Immaturity of glottic reflex also is there, as well as they are having habits of eating while crying and playing. And no doubt, the foreign body airway incidents are because of lack of parental supervision also. Site of lodgements can be from larynx to deep part of the airways, bronchus, and most commonly 80 to 90% occurs in the bronchus, that is mainly right main bronchus as per anatomy is there wider and right angle. Sometimes esophageal foreign body can penetrate or erode through the esophagus and lead to respiratory symptoms. So we are thinking that there is foreign body airway. So it mimics like foreign body airway there. When we are discussing the types of foreign body, they can be exogenous and endogenous. And mostly it is exogenous, that may be a metallic part, or as we had mentioned, vegetable foods in mostly peanuts, beans, seeds, or plastic toys. These organic foreign bodies, they are maybe decaying one that cause with the particles cause inflammatory reactions, irritations that lead to infection, edema. In these, all these nuts or seeds, they release linoleic acids that conjugated, and it will lead to irritation and inflammatory reaction to mucosa that lead to edema, or these are hygroscopic, they can swell with moisture and block the airway. So these foreign body as friable and fragments may be dislodged into other bronchus or deeper too in the smaller airways. So while we are managing, or the our surgeons is managing, should not be hasty. We have to make a plan, and then we have to proceed for bronchoscopy. So the clinical presentation depends on the foreign body location, whether it is in larynx or in main trachea or in right or left bronchus, the size of foreign body, the nature of foreign body, and duration of impaction when the foreign body was inhaled. The clinical presentation may be in three phases. The initial phase, when foreign body inhale, there may be choking, gasping, coughing, lead to airway obstruction also. And after that, there may be a asymptomatic phase, as the lodging of the objects with relaxation of the reflexes often result in a reduction or cessation of symptoms that may be lasting for hours or weeks. And after that, as period goes on, there may be complication phase, as the foreign body producing erosion or obstruction that lead to pneumonia, atelectasis, or abscess. And as the time passes, these chronic long-standing foreign body often present with misdiagnosis as a upper respiratory tract infection or asthma or pneumonia. So the diagnosis, we can say 50% occur in the first 24 hours, 80% within first week, and then later on. So when the foreign body loss, there is resistance to gas flow in the airway that is related to the fourth power of the radius. Means when there is edema is there, a small reduction in airway will result in large increase in resistance to the airflow. And in addition to that edema, there is physical presence of foreign body that result in rapid increase in airway resistance. So patient may present with, as mentioned, according to lodgement, coughing, continuous dyspnea, cyanosis maybe if infection is more, pain mostly when it is lodged in the larynx, tachypnea, rhonchi, intermittent hoarseness. And as we see, there is classic triads mostly, that is wheeze, cough, dyspnea. So what are the symptoms when the laryngeal foreign body is there? So there may be a sudden total or near total obstruction, that is initially cough, hoarseness or aphonia. Patient not able to speak and able patient with due to pain holding the tracheal parts. When there is tracheal foreign body, it's present similar to laryngeal foreign body but without hoarseness or aphonia. There may be hemoptysis if the foreign body is sharp enough because of the coughing that may lead to hemoptysis. Audible slaps. If mouth is open, we can able to hear that foreign body is moving up and down. Or if you are placing our hand on the trachea, we can able to feel that foreign body is sticking to all tracheal links that will lead to a palpative thirds. We can able to felt or asthmoid wheeze on auscultation, desaturation may be there, and expiratory stridor. So bronchial foreign body, when it is, there is triad that consists of paroxysmal cough is there, unilateral wheeze on the blocked sides, as well as maybe diminished air entry. So this picture shows that there is excessive muscles are working. In these foreign body patient comfortable in tripod position, we can able to visualize the cyanosis or intercostal muscle retraction at the intercostal level or at the diaphragm or diaphragmatic level. So in preoperative assessment, we have to check level of consciousness. The severity of airway obstruction has to be assessed, gas exchange, and mostly the fasting status, because in these patients we are sharing the airway and there is no intubation is there because we are working on the same track. So there may be aspiration chances. And as mentioned, the nature of and location of foreign body with the history, radiological examination or physical examination. With the lodgement of foreign body in airways, there may be to and fro movement of airway, that air that may lead to bypass mechanism. So two-way valve is there. But sometimes there may be one-way valve. That is, air can go inside the lungs but will not able to come. That lead to obstructed emphysema pictures. Or sometimes the airways caliber is so much less that foreign body get impact and there is no passage in and out, that may lead to collapse and atelectasis of that lung part. So diagnosis depends on complete history. We can able to make it clear with physical findings as well as investigation, whichever is feasible in that condition. Mostly we are able to get X-ray, chest, neck, but if time is permitted, CT scan, chest and neck will make a perfect diagnosis. So rule of thumb is when perform bronchoscopy, if there is history is witnessed with symptoms, and if not able to treat and there is suspicion, again then along with physical examination that gives some positive sign symptoms, along with if radiography is possible. So bronchoscopy has to be done on the basis of positive history alone also. So there are several studies which mention that the history itself in 90% patients suggestive of foreign body and bronchoscopy has to be done. While radiological signs can be there in 70 to 80%. So I am showing there's some clinical pictures. The patient presents with that. In our Udaipur is tribal area. Whenever there is any foreign body, the traditional method is doing hot iron burn. That is called dam. You can able to see in the patient, and this is I'm showing in next video also. So in this, as soon as patient came to us with difficult breathing, we have to oxygenate the patient. You can able to see there is respiratory difficulty is there in this video. In this video, you can able to see, appreciate jerky movements along with intercostal ingrowing is there. Accessory muscles are working there. This is just before induction of this patient. So the X-ray, in 20 to 40% cases, X-ray may be normal because mostly foreign body are radiolutions. But findings we have to check. There may be atelectasis, infiltration, consolidation, and if metallic foreign body is there, we can able to visualize it. So in these cases, when there is no metallic foreign body, we can able to visualize. It is beneficial that we have to take the X-ray in inspiratory and expiratory phase, by which we can able to appreciate there is air trapping is there, and that can lead to collapse or medicinal shifts. We can able to appreciate in this picture of 15-month baby having history of groundnut aspiration, respiratory difficulty was there, and because of the ball wall effect, impacted foreign body is on left side, but that lead to emphysema and shifting of medicinal to the right side. In this picture again, inspiratory accepted film that have both side right and left main bronchus showing collapse of left lower lobe. So with the inspiratory expiratory film, we can able to appreciate on which side the foreign body is lost. This picture shows metallic foreign body, that is safety pin, that is lying vertically, that is in means right bronchus. In this, we can able to appreciate the foreign body lying in the trachea in neck region, and in lateral view we can able to appreciate the foreign body lies in the air column. Again, this is foreign body safety pin, that is open position. In this, we can able to appreciate metallic sharp foreign body. And again, so the purpose of this that we have to take AP and lateral view, by which we can able to appreciate whether the foreign body is in airway or in our digestive tract, esophagus. Here the foreign body is metallic wire, that is able to appreciate, that is artificial tooth. The same picture, artificial tooth that are dislodged and lodged in the airway. Here we can able to, it is not a metallic one, but we can able to appreciate with density. It was a sand pencil. In local language we called as slate pencil. So CT scan, as mentioned, if time is permitting, patient is comfortable, or we are not able to diagnose, then CT scan is beneficial. So in this picture, we can able to say that there is, in this patient, it was a 4-year-old boy witness history of aspiration of groundnut as he was playing with groundnuts. So by this CT scan, we can able to appreciate left side lung collapse was there, and there is breach in the airway column. So whenever the patient present with difficulty in breathing, coughs, differential diagnosis has to be made. There may be, I have witnessed one patient who was treated for tuberculosis since 6 months in a periphery. When patient not get relieved, parents came to our hospital, X-ray was taken, and there was a nail that was remaining there since last 6 months. Bronchoscopy was done, and that metallic nail was removed. There may be traumatic injury with localized pulmonary airway or even diaphragmatic injury may present similarly to foreign body aspirations. So complication can be, but they are less with a safer hand. So what will be the management? If it is an emergency, we have to do emergency bronchoscopy. Or if patient is stable, we have to plan the foreign body bronchoscopy with availability of CT scan, flexible bronchoscopy. In adult, we can able to do the flexible bronchoscopy because pediatric patient we have to anesthetize. But in adult, we can do it with spray as you go with local aesthetics. So in all, if time permits, we have to optimize the patient condition and we should be ready if there is no ventilation is there or patient is getting sinus, cricothyrotomy earliest or tracheostomy as condition demanded. So preoperative preparation is always oxygenation. Fasting has to be checked. Investigation as mentioned as per need. The monitoring should be done, that is SpO2, ECG, and NIBP. IV assess has to be taken, and patient has to be optimized. If infection is there, antibiotics, anticholinergics, glycopyrrolate, bronchodilator, and steroids that lead to reduce the edema. And definitely, sedation is contraindicated. We have to ask OT to prepare, then gadgets that is for endoscopy and ventilation has to be done, and rehearsal or planning of what foreign body is or what may be, how we have to remove. I am stressing on this point because there may be sometimes we have to plan, and that I will show in my subsequent slides. So measures before bronchoscopy, definitely communication between the team, that is surgeon, anesthetist, and supporting staffs. So equipments, light suction, all that has to be neat along with the ventilation device, that is breathing circuits, jet ventilation, as well as we have to check the bronchoscope whether the bronchoscope ventilating port is patent or not, and one a proper size endotracheal tube that can fit in the bronchoscopy lumen. Here I am showing this picture of bronchoscope. Here this is the main lumen. Here we have to attach light source. On this side we have to attach the breathing circuits, and this is for oxygenation by venturi or pass a flexible equipments. We can able to ventilate either through this or we have to cap it and then we have to give oxygenation with jet ventilation through this. This is sharing of, we can do ventilation as well as surgeon has to be look into this as well as pass the forceps, rigid forceps through this. So this is venture device. Maybe some venture devices are there that have pressure limitation for pediatric as well as adults to prevent barotrauma. These are the various foreign bodies I am showing here because the team has to be checked whether we can able to pass that forceps or the suction tip through the size of bronchoscope. Here are the device grasping basket that can be utilized in certain condition. So with the rigid bronchoscopy, the success rate is 95% and complication very fatal as mentioned, less than 1%. Dislodgement of foreign body into more dangerous position can be there, and there may be hypoxic condition. So that has to be taken care by either oxygenation with the breathing circuits, or if it's not effective, joint ventilation. And we have to check the chest rise during ventilation is there, as well as management of mucosal bleeding. The surgeon will take care by placement of adrenaline swabs. So the goal of anesthesia is adequate oxygenation, IVSS, controlled cardiorespiratory reflex during bronchoscopy that can be managed by maintaining the anesthesia depth by IV anesthetic agents along with muscle relaxants. Then our goal is rapid return of airway reflex, prevention of pulmonary aspiration. So challenges in bronchoscopy are when we are attending the baby that is irritable. So difficulty in IVSS at that time, if IVSS is very difficult or patient is not cooperating, we can give intramuscular ketamine. Otherwise, mostly IVSS can be taken. Then sharing of airway has to be, we are taking care. The IV anesthetics that can be used is propofol, ketamine, or thiopentone. Mostly nowadays we are using propofol along with muscle relaxation because apnea has to be there. That can be facilitated by either succinylcholine or, if demand duration is more, then non-depressed muscle relaxant, atraconium or vacunium nowadays. Inhalation technique, mostly we are IV induction, then for time being we are ventilating. At that time we can able to use inhalation agent. Otherwise, during bronchoscopy, we are maintaining mostly on IV anesthetic agents, TIVA. So the anesthetic consideration that after once appropriate depth of anesthesia, patient is induced that handed over to endoscopist, and we are maintaining good communication along with we are doing the monitoring. So the technique mostly which we are using is either ventilating through the side of bronchoscope, or we are doing jet ventilation. But if we are, as I mentioned, there may be a chances of dilution of that inhalation anesthetic agents as well as OT pollution is there. I mentioned that we have to use a endotracheal tube. Sometimes we can use, as the bronchoscope is in the trachea, if we are difficult to ventilate through side port, we can put a appropriate size endotracheal tube in the main lumen of bronchoscope, and we can able to use the oxygen flush. I had used it. We can able to ventilate the patient easily with this. So after extraction of foreign body and removal of the rigid bronchoscope, the choice of ventilation during emergencies depend on the pulmonary gas exchange. If uncomplicated is there, then we can able to give support with mask, or we can able to simple by the polymask. If patient condition is not good, then we have to intubate the patient and taken care till we feel that patient is comfortable, okay. And post-operatively, we have to oxygenate the patient with humidified oxygen. And no doubt, post-operatively also, patient has to be monitored regularly. Previously, I mentioned that emergent cricothyrotomy can be required if we feel that patient is not able to ventilate, either by intubation, or if it's difficulty, then cricothyrotomy or tracheostomy according to condition. We had discussed Some of these intraoperative concerns, that may be loss of airway, because surgeon is trying to retrieve the foreign body and the same time patient deoxygenates. So we have to take care with good communication. If that kind of condition, we can able to ask the surgeon that they have to come in the main trachea, we have to ventilate, and then procedure can be proceed further. Sometimes during removal of foreign body, it become hang up at vocal cords or in trachea. So there may be sudden total airway obstruction. So what is the solution? As I mentioned, endoscopist may need to use a scope to push down foreign body in one of bronchus and then again ventilate and then proceed regroup or reoxygenate them. So what is the post-operative management? Mostly there may be continuous coughing, irritational coughing. So with bronchodilators, we have to use racemic mixture of epinephrine can be used. Steroid we has already given at the time of induction. We can have to examine the patient physically, or if required, we can arrange bedside X-ray. Sometimes some foreign body requires repeat procedures as per diagnosis later on, and patient should be observed 12 to 24 hours post procedure. You can able to appreciate the distress baby is having using accessory muscles, continuous coughing with intercostal retraction also. Tachypnea is there, dusky, sinuses. You can appreciate the dusky, not sinuses. The same patient under procedure, we are ventilating through that side arm. Surgeon is proceeding, and whenever time available, we have to ventilate. The monitoring is there, 100%. Other surgeon remove forceps, the time is there, again ventilate. The same patient after removal in the recovery position, as I mentioned, there is irritational cough is there. So it will remain 12 to 24 hours. That's why patient has to be monitored regularly. We have done a study in which we observe 73% are vegetative organic foreign bodies, and most of foreign bodies are having obstetric emphysema is there, along with collapse, consultation, and no doubt normal X-ray. As studies has mentioned, normal X-ray can be there in foreign body airway. Now I am mentioning some case reports with their take-home message. As I previously mentioned, esophageal foreign body can mimics like airway foreign body. I am presenting two cases. This is a boy of 25-year-old that reported in Journal of Anesthesia Clinical Pharmacology in 1997. The patient admitted with history of dyspnea, cough, that was admitted in medical ward, and he was not responding. On third day, they called us, my colleague, I think all of you know, Dr. Vikram Vardhan. We appreciate that both side air entry was so much dimness. We asked them to make a CT scan. Patient was shifted to CT scan. They reveal somewhere foreign body at the level of third thoracic vertebra. Immediately from CT scan, patient was shifted to emergency OT. Bronchoscopy was done. First attempt, it was not able to appreciate because of the whole lumen is obliterated. They said that that is carina. but that was not a carina. It was foreign body penetrating from esophagus to trachea, and whole tracheal lumen is obliterated with granulation tissue. With the bronchoscope, there was bleeding, and patient get cardiac arrest, CPR done, and it was fatal. So the purpose of presentation of this case that history should be evaluated. When the history was evaluated, as we had mentioned, air entries decrease, and it was evaluated that there was a history of food 3 days back that was meat bolus. So we have to do history, physical examination along with investigation, that may be X-ray, or in this case CT scan reveal that there was a foreign body puncturing from esophagus too. So always make a suspicion. Early flexible bronchoscopy, if possible, that has to be planned in adult one. And in this case, if CT scan was done, suspicion was done early, thoracotomy can be planned. And with this report, we have should be ready for any catastrophe that has to be mentioned to parents also. This is second case, 2-month-old child presented with history of fever, respiratory distress. X-ray chest shows metallic foreign body, and the surgeon has put a emergency OT list mentioning foreign body coin. Patient was induced, and after induction, it was very difficult to ventilate. I have done the laryngoscopy. That why what is the difficulty is there, but I am not able to see the larynx. Then I have evaluated further. I able to visualize a palate concha in the esophagus. We had measured after removal, that was 16 millimeter. That foreign body palate pushing the larynx anteriorly and obliterating, that make difficulty in mask ventilation. Then I ask the surgeons to, is there any lateral view? Then they say that yes, we had lateral view. They had not seen that lateral view. On the PA view, they appreciate that there is coin is foreign body. That foreign body palate was not able to remove by the available forceps. So it was planned to do tracheostomy, and later on we can able to remove the foreign body through tracheostomy. This is the picture of that palate. So the take-home message with this is esophageal foreign body can mimic like tracheobronchial foreign body. Always, whatever foreign body is there, always we have to take AP and lateral view and take all measures and then plan and ready for tracheostomy. This is another case of 3.5-year baby with witness history, having 6 days vomiting and cough history. Bilateral clefts were present there, and impacted foreign body was broken safety pin. Planned for bronchoscopy but not able to retrieve it. Then thoracotomy was done and foreign body was able to remove. So when bronchus foreign body failed removed by bronchoscopy, that may be because of the delayed presentation or it is so much impacted. So we should be ready for conversion to surgery, means plan B should be there. Another case of 12-year female child that have 4 hours witness history. Tamarind seeds aspiration was there. There was no complaint. Only witness history was there. This is the time of elective OT. The patient was called in main elective OT. I have examined. I can able to feel the audible claps as well as palpative third was there. So the table was free. We are preparing, and that baby was standing. Suddenly she get collapse and sinus. Immediately we put it on the OT table. Surgeon asked that kindly under this. and I request that patient is sinus, bradycardia, kindly go ahead. I will do simultaneously the things. The foreign body was immediately removed because we had already set the bronchoscopes there. Later, I able to ventilate the patient by mask and recovery was uneventful. So the take home message with this is be ready. If patient is sinus, unconscious, body relax, no cough reflex, we can able to proceed immediate bronchoscopy. Along with, we have to do all measures. So another case of 3-year-old child with esophageal foreign body coin. The foreign body was easily removed after intubation. Extubation was done, but immediately patient gets sinus. There was no respiratory movements. I can't able to make mask ventilation and intubation also. At the time of negotiation of endotracheal, it can't able to push below the larynx. So there was suspicion that patient is critical. I immediately gave chest compression, and after that, patient improved. Laryngoscopy done, oral cavity examined. There was a piece of betel nut was there. Now I can able to ventilate. We again reveal the history from parents. They said that yes, during fasting period we had given a meaty supari that is available nowadays in pouch. That a betel nut was there in mouth during endoscopy, and that slip in the larynx and that cause blockage of airway. So the take home message with this, we have to evaluate the history complete. It doesn't mean patient say fasting. Fasting means only and only air or oxygen in these kind of critical cases. And after removal, it is dictum that we have to evaluate oral cavity if it is organic foreign bodies. But in this case, there was no organic foreign body, and because of the parent negligence, there was a foreign body. So we have to evaluate oral cavity after removal of foreign body. There may be some fragments or some other things. Here again, interesting case of 12-year-old boy while playing with siblings aspirated toy piece. We can able to appreciate the some pinchu toys are doing when we are pressing. That piece was inhaled, and during each inspiration and expiration, there was whistling sound was there. That whistling sound because of there is a hole in between that make aeration. Patient survive because of that simple hole, and that cause sounds also. And that foreign body is enough size that impacted in tracheal rings. That was removed successfully with hooking that foreign body, and this is was the foreign body of 18 millimeter diameter that was impinged in the tracheal grooves. So in this case, we had already planned how we have to remove it because we can't able to remove with the ordinary forceps. It was planned and hook was prepared, and we can able to retrieve it successfully. Another case of 9-year girl presented with respiratory distress. X-ray chest shows right side collapse, consolidated lung, mediastinal shift to right side. CT scan reveal foreign body right bronchus. Bronchoscopy was done, but foreign body not removed via larynx because it was swollen and impacted. Then bronchoscopy was done through tracheostomy. A tamarind seed were removed. We can able to appreciate right side lung totally collapse in CT scan. And after tracheostomy, it was able to removed. So the take-home message is we have to prepare ourselves if foreign body is large. We have to plan it, and whenever required, we have to do tracheostomy to reduce morbidity and good outcomes. This case of open safety pin was impacted, and we are worried that while we are removing, it can puncture, it can tear the tracheal lumen. So, with this, take home message is take caution while removing sharp foreign body. And in this, our surgeons make efforts to make it slightly close or clamp the pointed end with the forceps and able to remove it. After removal, we had again done a second look to check whether there is any bleeding or mucosal tear is there or not, and that was confirmed with oxygenation, ventilation, mask ventilation, along with a check X-ray was done. So, in nutshell, the word of wisdom when we are dealing with airway foreign body, physical and radiological evaluation is helpful in localization and identification of foreign body. Normal chest X-ray doesn't rule out foreign body. All that we is not asthma. A team efforts is required. Means good communication should be there. Positive history of choking followed by coughing is an indication of bronchoscopic removal should be done as soon as possible. Practice with a duplicate foreign body and planning has to be done. As I mentioned, be ready and equipped with all possible equipments. Constant re-evaluation should be there, and don't run a non-obstetric foreign body into an obstetric one. Don't miss the second foreign body. We have to go and look for another piece. So not all foreign body can be removed endoscopically. Consider surgical option also. So each case should be dealt in a specific way. As I mentioned, 9-10 cases. Some few minutes more. If we are not able to do bronchoscopy, or if the situation is like that, so how to resuscitate the patients? If baby is there, we have to make back blow, 5 back blow in inverted position, then turn, then give chest compression. So by this, we can able to remove the foreign body. If it is adult one and conscious, we had heard that Heimlich maneuver will be helpful in this. So by grasping our thumb and give a pressure towards jiffy, inward and upward thrust, the object can be expelled. If patient is unconscious, then we have to make the patient supine, and Heimlich maneuvers has to be done at the level of G-piston. Below that, if it is pregnant lady, the, then we have not to do Heimlich maneuver. We have to give a mid-sternum chest thrust. I have purposely mentioned here some literature mention. Suppose you are alone and stuck in that situation of food bolus or something foreign body in airway. How we have to resuscitate ourselves on. So in that condition, we have to do on ourselves Heimlich maneuver, or we have to press upper abdominal parts, that is gestational part, on the edge of the chair, sofa, with a several thrusts that may be helpful. And one last slide, the prevention, definitely. On the packaging of toys, we have to label that is harmful. Nowadays, these are all mentioned in every toys. New onset of wheezing, coughing, drooling, voice changes. Postural should alert practitioner and parent to the possibility of foreign body aspiration. Or if that patient is not responding to treatment, then again make a suspicion. Sometimes a mucus plug can lead to that kind of obstructive feature. and food other objects with a smooth round surface are at high risk. So don't give them to the baby. I take privilege to invite you all to Udaipur. We are holding All India Difficult Airway Association's 16th National Airway Conference on 12 to 14 September that have two workshops also. Along with, we are organizing a workshop for the exam going students. Thank you very much. Thank you.
Vineet, are there any questions in the chat box? Abhirup?
Good evening. Yes, ma'am. So thank you, sir, for the very enlightening talk. So we have one question posed on the chat box by Dr. Priyanka Goel.
Please, sir.
So Dr. Priyanka asks, how much pressure is ideal for adult patients during manual jet ventilation to maintain oxygenation?
Yeah. As I mentioned, nowadays the jet ventilation is 60 psi directly, but one device is available from VBM that have two options. They had marketed it, but nowadays, since I have inquired because we want to purchase, that is out of market now.
Anything else, Abhirup?
Right, sir.
No.
That is the only question posed as of now, ma'am, on the chat box.
Okay. Lovely. Dr. Lalit, thank you so much for that very important lecture. And I like the way you discussed all the cases with all the practical cases that we have, incidents. And it was such a well demonstrated program. And really, the students and we too have really enjoyed it a lot. And some challenging tips that you gave to all the students and us are really creditable. And truly, this is such a challenging case if we get in during an emergency. At least in the daytime, we have everyone to help us. But at night, when there are not many senior consultants, becomes difficult.
Definitely,
So,
ma'am. Purposefully, I have mentioned these 10 cases that I came
yes,
across.
that's right. So when
And
they're not very common, but they're seen in during our time as professionals. So it's so important and challenging these cases are, and immediate help. And as you said, you have to plan out. You may not have time, but still you should know what are the steps that you should do to rescue the child.
yes, ma'am.
Very
And I am
well.
in habit of collecting these things, taking
Yes.
video, photographs.
Yes. Very, very interesting talk.
Yes.
Thank you so much, Lalit. Thanks a lot.
Thank you
And
again, ma'am,
yes.
for giving me opportunity. Thank you very much.
Thanks a lot. Thank you,
Thank you.
Abhirup. Thank you, Vineet.
If there is
Thank
any
you, sir.
query, ma'am,
Yes.
Thank you,
kindly
ma'am.
post me. I will be happy to answer them.
Definitely. Thank
Yes.
you. Definitely.
Thank
Thanks
you,
a
ma'am.
lot. And thanks. Thank you, Shreyashi. And thank you, Abhirup.
Good evening,
Thank you,
ma'am.
ma'am.
Good
Thank
evening,
you so
sir.
much.
Thank
Thank
you,
you.
Dr. Vineet also.
Thank you,
Thank
Vineet.
you, sir. Thank you, sir. Yes.
Thank you so much, everyone. Thank you. Good night to all
Thank
of you.
So we
Good night.
see you
Have a
all
nice
next
day.
week.
Yeah, ma'am.
Thank you so much. Thanks a lot. Good night.
Bye.
Good night.
Good
Good
night.
evening.
Good night.